I told Richard that was the shortest I'd ever heard John Spertus ever talk. So I don't know how he did that. But well, thanks for inviting me. You know, I've been a doctor for over 30 years, 35 years. I've only been in administration for about 10 or 11 as a medical director and as a director of medical affairs, and ultimately as a vice president of the hospital. I was vice president of medical affairs and just recently became a vice president of research and medical education. I was fortunate as a physician in medical school to go to a medical school where I did have good role models on the clinical side of learning to listen to patients and to pay attention to patients. And John mentioned his experience. One of my, I think, unique experiences probably for this audience is that we did have a department of bioethics and medical humanities, and this was in the 1970s. There weren't a lot of medical schools that had that. I remember that I think we had that for 2 semesters, one semester first year, one semester second year. And I remember one of those years, the class was at 3:30 on Friday afternoons. And I remember the other semester, it was like at 7 a.m. on Monday morning. So it kind of got squeezed in most of our lifestyles. But while I was in that class, we had a visiting professor invited by one of our professors who came and spent a couple of months, and we didn't know this individual at all, and that she was taking some time out of her other job to finish a book. And anyway, it turned out it was Elizabeth Kubler-Ross that probably some of you have heard of, and maybe some of you have met along back then. But so it was amazing having somebody come and talk to us about stuff that as medical students you never even thought about, you know. And she wasn't. How many people ever met her or heard her? You know, she was an interesting person, very engaging. She chain smoked about, I think, 3 packs a day right in the classroom. I remember that. But anyway, but very interesting person, and really got us engaged in thinking about things as students that then later on I think has always played an important role in my life. Now, hospital administration in hospitals, I'm just going to kind of put that into a category, historically really didn't have to listen to patients. Hospitals historically were places that people didn't want to go and didn't ever look at as being a positive experience. And if you go way back in history, in the early part of the century, I mean, going to the hospital was going to somewhere to die for many, many people. If you could be treated any way other than hospital, that was best. Hospitals and administrators listened to the doctors, and they listened to their board, but I'm not sure they paid a lot of attention to patients. And part of that was because that the hospital was really a shop where the craftsmen, who were doctors, independent of the hospital, they weren't owned by the hospital, but where the hospital created a shop for those craftsmen to do their trade. And so they really were accountable to the doctors. And that model was one where patients were there because largely the doctor told them they needed to be in the hospital. They didn't intend it to be a luxurious experience. It was generally thought that the food was bad, the facilities were, what needed to be there, and they wanted to get in and get out and leave in better shape than when they came, and that was what they hoped for, and many times that's what they got. Care was administered, and it's interesting, if you go to many other parts of the world, that's still kind of what a hospital is. It's a lot different than in the United States. Patients didn't shop for hospitals. They didn't go to find the best looking hospital or the one with the nicest rooms. They just kind of went where they were told. Now, probably really about 15 or 20 years ago, I think hospitals and hospital administrators, certainly in some parts of the country, began to learn a little bit more about what was motivating patients of what they were beginning to see in the hospital experience. Probably initially this was driven by competition. You have communities like Kansas City that has, 20 hospitals where the number of beds, we have several modestly large hospitals, a lot of medium and small-sized hospitals, probably 3 or 4 hospitals could serve the community, but there began to be competition, and hospitals had to look at that. A lot of what administrators were listening to, though, I think, rather than patients, is they were listening to people in marketing, they were listening to people in hospitality services, they were listening to people that who contracted to do various things in the hospital and build various things. And what then they thought patients were saying is they needed bigger rooms, bigger TV sets, 24-hour-a-day food service, menu service, all kinds of things that courtyards, statues, fountains, various things that we all, as hospitals, got into. So hospitals recreated themselves. They built new buildings. They're still building new buildings. They're creating amenities. They also embraced technology as somehow if you had the newest technology, that made you better. And so generations, companies are not stupid. So if you invent a device, you're probably going to invent the next generation about 12 or 18 months later. So you're replacing something you haven't even paid for yet with a new one. And hospitals bought into that. They created centers of excellence. They created centers of care to kind of silo services. And I don't think they really were learning that from patients. I think they thought they were doing what patients wanted, but I don't think that's what they wanted. I think when hospitals began to pay attention to what patients wanted and what patients were concerned about, and we'll talk about why that happened in just a second, what they really found was patients wanted somebody to listen to them. They wanted somebody to help them understand the kind of matrix of care that would happen. It wasn't their family doc admitting them to the hospital and treating them. There were all these care providers who weren't even sure who the people were that came in the room from time to time. I'm sure a lot of you around hospitals know patients will tell their nurse, well, I wish, the doctor hadn't been here for 3 days. Well, they didn't even know who the doctor was that came in the room, because of all the numbers of people that came in. They wanted to have somebody help them understand what was being ordered and what tests were being done and what was going to happen tomorrow, and somebody who could sit down and talk to them so they weren't suddenly rushed into these decisions or suddenly finding out they're having a test. They wanted to know about risks and benefits. John was talking about that. What's this mean if I'm going to have this procedure or that procedure? Yeah, I signed a consent form, but that was probably a resident who was told to go in and get a consent, which meant you got their signature on a piece of paper, and people would sign it. So there were a lot of things I think that people were concerned about. And while some may complain about the food or the parking or so forth, that really wasn't it. Hospitals, I think, began to look at these things. They began to look at certain Joint Commission and Medicare guidelines that made this occur. They began to hire physician advocates. When I was the Vice President of Medical Affairs, I met every week or at least every other week, but usually every week with our patient advocates. The incredible things that patients complained about and families complained about. But the most single common theme, other than occasionally about parking or the food, was communication. They didn't know what was going on. They didn't understand. The family didn't understand. The patient couldn't explain it to the family. Nobody else was around. Repetitive things like that. Another thing the hospitals got into that I think is important, and we have participated in a program with about 60 hospitals, is realizing that patients who didn't care for their doctor very well were patients that tended to sue hospitals and sue their doctor. And that, in fact, if you looked at doctors that didn't like their patients and complained a lot about, patients who didn't like their doctors, maybe the other way around too, but patients that didn't like their doctors, if you looked at those doctors and you looked at the doctors that were the role models at the hospital, clinically there wasn't much difference in outcome. There have been large studies that have looked at this. Doctors that patients don't like probably have about the same outcome as the doctors that people like. But the risk of liability was vastly different in those two groups of doctors. And so we've participated in a program that addresses that and provides some benchmarking nationally and so forth to help. So finally, though, what I think has happened, as you may know, is now we're being incentivized to have patients have a good experience. And what started now with Medicare and will probably flow into the private payers is that there's a potential loss of maximal reimbursement for care you provide if patients don't have a good experience in the hospital. That's one of the metrics that we're being measured on. Data is collected, and that will impact our reimbursement to the tune of several percent. And that's when you have a margin of about 1%, several percent in reimbursement is significant. And so some of you have probably heard of, these things are called pay for performance or value-based purchasing. You've probably heard of HCAHPS, you know, which is one of the major organizations that do these surveys of random number of patients after they leave the hospital, what their experience are like. And you know, they survey about nurses, they survey about physicians, other clinicians. And the questions they are asking is, did the nurse treat you with courtesy and respect? Did the physician treat you with courtesy and respect? You know, did they listen carefully to you? Did they explain things to you? If you pressed the call button, did someone answer it? And when they're talking about physicians, did he or she explain them in a way you could understand them? Not did they explain them, but was in a way that you could understand them. And so these scores are then put together, and they are reported nationally, and they're reported, and Medicare looks at them, and they can impact how they are impacting how we get paid. So medication errors, physicians' attitudes, nursing attitudes, preparation for going home, discharge, follow-up are all part of that HCAHPS summary of patients. So these scores are put together. We can also benchmark them against ourselves or like-type hospitals. There's a consortium of kind of teaching hospitals. I think there's 110 or 115 hospitals nationally. Truman, St. Luke's, and KU Hospital are, I think, the three local hospitals that are in that, and we can look at the scores across that type of benchmarking with teaching hospitals. And this will begin to build, I think, as commercial payers use this type of information. So I think that maybe partially driven by incentivization, partially driven by the economics of not being able to continue to build hospitals that look like resorts. I think administrators are listening to patients, and they're realizing the real important things. What was the experience like? Did people listen to me? You know, if I go home, do I really know what I'm supposed to take? And what I do with this big bag of medicines and all that kind of stuff is very, very important right now. And I think that hospitals that were working on this previously for 5 or 8 or 10 years are going to do better in these systems of compensation. So as finances get tighter in hospitals, that's going to be an important thing going forward. So,
Great.
Done.
Thanks.